On where? On the computer. There is no one.
Her blood pressure.
Okay.
Um,
Her blood pressure's low. I agree.
a little low, 98 over 50, although her lying was normal. There's a big difference.
Okay. So her blood pressure's low. Are you concerned about her pulse rate or her respiration?
Yeah.
Okay.
Her pulse.
And she's received she's received a bolus of 500, so a half a liter. So should we have any additional concerns?
Is the volume down?
Say that again. Should we have any additional concerns?
Well, maybe she's getting a little dehydrated with the vomiting and diarrhea.
Okay. Definitely there's some dehydration there because blood pressure's low, heart rate's up. And although we've given her the bolus and she's getting fluids at 150 per hour, when we get to her assessment here on the unit, she's lethargic. The NG tube is clamped. Lying down, her BP's 110 over 74, heart rate's 100. Then we have another lying BP, and I think they probably mean when they sat her up. Her blood pressure dropped, and then her heart rate went up. And then when we stood her up, because that's how you should do an orthostatic, it should be BP lying down, then at a 45 to 90 degree angle, and then standing up. So each time her blood pressure dropped more than 10 points, correct? What's the rule about orthostatic readings and what's considered to be positive or negative?
Isn't it like 30 difference of 30 points?
Is that true?
I'm trying to think. I'm trying to go by memory.
I don't know how to talk.
Anybody else? Let's see.
They can't hear me.
So you can also type in your answer.
Where? See, it says microphone wireless stereo headset. This is it, right?
Maybe you need to.
Is there something that comes down that you're talking to?
Oh. Maybe you have to push that button.
So orthostatic, when you're having an orthostatic blood pressure issue, then you either have a decrease in the systolic pressure, or you have a decrease, that's the systolic, or you have a decrease in the diastolic of 10. And your heart rate usually goes up, becomes more tachycardic, correct? So you gotta understand what the orthostatic component is. Correct. Normally the question was, shouldn't your blood pressure rise when you stand? Yes, it should. That's what happens when you don't have a volume deficit. So when you have a volume deficit, the blood pressure tends to drop, which is the reason why you're looking at it from an orthostatic standpoint. So when the blood pressure decreases on the top side by 20 or on the diastolic side by 10, then we're losing volume. So in a normal person that doesn't have any volume deficits, then you would expect the blood pressure to go up. Now, what should not happen is that your heart rate should not increase into the 120s or even the 1-teens for that matter. But here we clearly see that the heart rate went from 100 to 128. And our next sign that we have a problem is the skin is pale and cool, right?
Mm-hmm.
What's going on with our skin turgor?
Dehydrated.
Is our skin turgor good? She's
No.
dehydrated. She has poor skin turgor, so that's another sign of poor perfusion. Okay. Oral mucosa dry, again, dehydration. So she's had 2 bouts of vomiting and 2 bouts of diarrhea in the emergency room. Okay. All right. So here's our first question. Based on the assessment data, what nursing diagnosis, and this would be actually what patient priority concept is what we're looking at now. What concept priority would be most appropriate for her?
To give her fluids if she's dehydrated.
Okay. Fluid and electrolyte imbalance. Okay. So she does, I would be worried about some electrolytes since she's dumping out, right?
Mhm.
Vomiting and diarrhea. Okay. So fluid volume deficit is what we have. Woo. Can't get my fingers to roll here. So she's thirsty, dry mouth is, her mouth is dry. She want to know, can she have a glass of water? Can you give her a glass of water?
I would say no, no, you wouldn't, because if she's dehydrated, she wouldn't be able to hold the fluid. So if she's going to get any fluids in, she would need to do something like ice chip, something extremely small.
Uh-huh. Okay. So the doctor gave some orders. So based on the doctor's orders, let me scroll up. What's the first thing?
Oh, it's NPO.
She's NPO. So we can't give her anything to drink, but what we can do is, we can check with the doctor and see if she can do like a damp cloth or something like that. But we're not going to give her any water because she's nauseated and she's been vomiting. So that's not going to help her situation. All right. So the doctor has ordered that you have nothing to eat or drink. We can swab the mouth to help with the dryness. So don't have it saturating, where the water's dripping. Or you can use those green sponges that they use for oral care. You can use that as well. All right, so we're going to develop a plan of care based on the nursing diagnosis. So now we're going to look at fluid volume deficit. And so what are some things we're going to utilize? What are we going to do? She already has IV going, right?
Correct.
Okay. Okay, rest. Yep. INOs. Give her the medications as ordered, vital signs. Yep. What else?
Would you want to continue taking her orthostatics after?
I mean, let's find out why she has this gastroenteritis. Is this like bacterial? Is this viral? Because she does have a temperature.
Maybe lab CBC.
Right. Get some labs, CBC. I'd get a chem probably a Chem 10. You look at her electrolytes to see if her potassium or sodiums are out of whack, because then that would bring on some additional problems. But we already did vital signs. You know, continue to check her skin turgor, skin color, temperature, condition. So those would be some of the things that I would look at. Make sure her IV site's good. You know, if she does have any electrolyte imbalances, then correct those. So give those antibiotics if needed, antidiarrheals if needed, antiemetics if needed. And then, you know, gradually increase her diet from MPO to clear liquids, full liquids, etc. Does that make sense? Okay. So let's move on. So these are our labs. Do we have any concerns? And if so, what are they? All right. Her potassium's low too, isn't it? Isn't it 3.5 to 5? Okay. So, let me pull something up real quick. No, that's not where I wanted to go. Okay. So I'm going to bring up some lab values. I'm going to share a different screen. So here are all of our basic lab values. Can you guys see these? Okay. So if her potassium is 2.8, then we're well below where we need to be. And since she's nauseated and she's in PO, we probably won't give her PO potassium supplement, but probably KCL IV. So, you know, hopefully she may have another IV available and we can give it directly there, right? Okay. I'm gonna go back to the case study. And there we go. All right. So next question. So what do each of the lab values indicate? What is the normal range? So we just kind of went through that anyway. So I just pulled up the picture of, you know, normal potassiums 3.5 to 5, which was, so she has hypokalemia. Her sodium's 125. Normal is 135 to 145. So she has hyponatremia, right? Yep. And then we are the other labs good? Okay. So everything else seems to be within normal range with the mag and the chloride. So magnesium is 1.0, and normally it's a little bit low. The magnesium is a little bit low. So it's 1.5 to 2.5 is the normal magnesium. Chloride is 95 to 105. That's the normal. And so for her, slightly low. slightly low. All right. Based on these, what would be your priority for this patient, your priority assessment? So our two key issues is the sodium and the potassium. That's going to be our big ones. And remember, in order to get the potassium up, we'd have to give what first? That was right at the end of the lecture. We talked about that.
Calcium.
Not the calcium. Isn't it the mag?
Yes.
All right. So yeah, we did if we have both of them low, we need to give that mag so that way we can get the potassium back up. That was the last thing we covered right before we broke from class. All right, so now what is our concern with the sodium? Because our sodium is low too. Nerve conduction, okay. Are we going to give the K-exolate for which one, Lissa? For the high potassium. We can't, but the potassium isn't high though, is it? We have a low potassium. We have a 2.8. Okay. So not that you're incorrect, but just for this person, we wouldn't want to do that move. We have hypokalemia. So we'll probably give them IV infusion. That's probably what we'll end up doing for this individual. And then we may be looking at some other therapies. You know, we may end up having to do the 3% sodium. Because our level is super low. So we may have to watch that. They consider the critical values less than 115. 124 should be your lowest point. So he's 125, correct? Is that what that was? So we won't need to do the 3% sodium at this time. So usually that 3% is when it's less than 120 is when they're going to recommend, when the sodium is less than 120, recommend doing the 3% sodium. And are we going to give that fast? Or are we going to give it slow? How are we going to give it? We're going to give this slow. And why are we giving it slow? What are we trying to prevent? We're trying to prevent hyper, but what are we also, when we have it really, really low, when the sodium levels are super low, what's our concern in relation to the brain? Cell destruction, okay. Was that cerebral edema? Yeah, so we don't want to give it fast, because if we give it too fast, then we can end up with giving the patient cerebral edema. So that was one of the things we talked about as well. But we give that 3% sodium solution. Is that a hyper or hypotonic solution? It's a hyper, P-E-R, correct, Latrice. So that's going to shrink the cell, pull the water out, and that can cause volume overload. So if we're giving it, then we're definitely going to be looking for hypernatremia. So we have several pieces working here. We have to correct the mag, we got to correct the K, we have to correct the sodium. Okay. All right, so let's move on with this case study. Based on these findings, what would be the priority assessment? So I'd be looking at neuro, I'd be looking at cardiovascular, I'd be looking at respiratory. They complained of the abdominal cramps. Well, that would coincide with what? Hyponatremia, a hypokalemia. Which one? Or both? So you got to go back to your notes because I put that on the board. That'd be hyponatremia, and that's because of the salt loss. So abdominal cramping and change in mental status or confusion is very prominent with a hyponatremia. All right, so what medical management might the nurse anticipate for these findings? Okay, we already talked about potassium replacement, sodium replacement, additional labs to see if the numbers are going up, giving magnesium, right? Given the antiemetics, let's figure out why we have the gastroenteritis. So if this is bacterial, so monitor that culture and sensitivity that was part of the admit orders. So at the end of your 12-hour shift, here's our INOs. Are we good here? Have we gained any ground? Yes or no? No. We are still at a deficit. So we have taken in 1,500, but we have more leaving out the body. So we have diarrhea, we have the NG, that's to low intermittent wall suctioning, and then we have vomiting. So we're still losing ground. Oh, forgot about the urine, my bad. So that makes this deficit worse than we originally thought. All right, so what should we conclude from these findings? I think we've already said that. We have more output than intake. What should be our priority assessment for this? I'd be checking mental status, electrolytes, because even though we're putting in more, or we put in fluid, we need more fluid. Even with the bolus, she was still under. She got a 500 cc bolus, and that, should we check respirations, and if so, why? And when they say bolus, they're basically talking about a fluid challenge. That's another term that you may hear it called. So if we give her too much, we could see fluid ending up in the lungs. That is true. So we want to assess the respirations to make sure we're not going from volume deficit to volume overload. So that is correct. But I think because she is 65, 68, if I remember correctly. So now we need to make sure we're not overloading the lungs. But I think we're good here because she still seems to be behind the 8 ball. All right, so assess for signs related to fluid volume deficit, and then what that represents, which we've already kind of covered that already. What interventions would be appropriate? We've talked about that as well. Call a physician, and this is from the INOs. and then anticipate orders to increase the IV fluid. She may get an additional fluid challenge, give her the antidiarrheals and the antiemetics, so that way she can stop losing fluids from the mouth and the rectum. So we're on day 2. You're doing your assessment. She's extremely anxious. She can't lie still. She's trying to get out of bed. She's complaining of nausea, muscle cramping in her legs. Her BP is higher when she's lying, and it drops more than 20 systolic when she's standing. So what do we call the physician, and this is what we get. And then we need to call the results. Back to the physician. So what condition does she have now? Why do you think she has the muscle cramping? What is that related to? And we just talked about that a minute ago. The low sodium. So hyponatremia. So the nurse's actions what nursing action should you take while waiting for the labs to return? Increase sodium. Okay, because she's getting D5-LR. So maybe change that LR to NS. We can't feed her, so everything has to be IV. So provide a safe environment, because as that sodium continues to drop, she's going to become more confused. We need to see what the current sodium level is. The last one was 125. So if she's dropped lower, then we need to consider that 3% sodium chloride. Can we do which part without an order? The safety? Which one? The challenge. Changing IV. These are things to anticipate, but up until then, we got to wait for it. We need the number to determine if we're going to change it to sodium. So I'm just basically saying these are the things that you should be anticipating as orders coming through. All right, so we get our lab results, 117. What are we given now? Yep, you can expect that 3% to come through. So what implications would be indicated for a client with a sodium level of 117? They would probably be close to comatose when you think. Muscle twitching. Fatigue, more nausea, more vomiting, more cramping. Water restriction. So she's NPO, but we need to make sure we're not even using water in the NG tube. Neuro checks every 4 hours. Safety, strict INOs, get daily weights, monitor her serum sodium, and specific gravity. Okay. All right. What orders should the nurse anticipate the physician ordering based on the latest findings? We've already said the 3% sodium, transfer to the ICU. Let's double check that. All right, let's verify in that IV fluids packet that we looked at in class. All right, so I think this is a typo right here, because shouldn't it say hypertonic solution? What do you guys think? Is that 3%? Should this be a hypotonic solution or a hypertonic solution? All right, so go find that IV fluids article, IV fluids, what nurses, and on page 35, page 35 and 36. So hypertonic sodium chloride solutions contain higher concentration of sodium, so they're hyper, PER is what we should be doing here for the hyponatremia. We need to use a hypertonic solution. So this is a typo. So make sure you don't confuse it. 3% sodium is hypertonic, PER. There we go. And yep, give it slow. And then that should be the end. Okay, so are there any questions about Blame It on Grammarly? I love it. All right, so what are your thoughts about kind of opening with a scenario for which we covered in class? So I think that kind of gets everybody back on the same page. So let's move to hyperkalemia is where we're going to go next. And hyperkalemia is going to be any value over 5, correct? So this is, and then it becomes critical when the potassium is 7.0 or higher. So normally, potassium, is it inside or outside the cell normally? Okay, it's inside the cell. So in hyperkalemia, it is no longer inside the cell, it is now outside the cell. So that's the difference here with between hyper and hypokalemia. So there's several causes like renal failure. You can have potassium sparing diuretics. So it'd be like your aldosterone, not your aldosterone, what am I thinking? Spirulactone, that's the one I'm looking for, spirulactone. High potassium intake, adrenal insufficiency, burns, and starvation. So burns, starvation, K-sparing diuretics, renal failure, those are all going to be causes of hyperkalemia. And renal failure would be because of the fact that they can't pee it out, so they may be on dialysis and all of that. How would you expect the patient to present? What would be some of the presentations from this individual? So like your signs and symptoms. Fever, not necessarily, but more like neuro presentation, those types of things. Muscle weakness, they definitely will have that. Respiratory impairment is a potential. Hyperactive GI system, anxiety, cardiac changes, and that's usually your big one. So remember with hypokalemia, we had the U wave, so we had a QRS complex, and then we had an extra U wave. Not necessarily tachycardia. However, so when we see, let's see if I can draw this. This is what I'm gonna see if I can share this. Now don't talk about my drawing, by the way. All right, so I'm gonna share this little whiteboard, and one of the there's several cardiac changes, but one of the main changes is going to be, so you have your P wave, and then you have your QRS, and then this is going to be your T wave. So what's different than the T wave that we talked about in class? What do you notice about this particular T wave? Is that how it should be? Picasso. It's going to be peaked and tall. So one of the changes that you will see with hyperkalemia is that the T wave here will always look like a TP, or it's going to be tall, it's going to be peaked, and this isn't normal. Because normal, when you do a T wave, it looks like that. So this here, when it looks like a TP, then now we're looking at hyperkalemia. So every QRS complex will have a tall, peaked T wave. Patients will have nausea, vomiting, and potentially diarrhea. Wide QRS. So this is why I made this one a little bit bigger than this one, okay? So when they mean by wide QRS, so here's our P wave, and then this is, all right, don't talk about my drawing, but I think you get it. From here to here, from that length there, that should be less than 0.12 seconds. It's going to be greater. It's almost going to be like a premature ventricular contraction. And that's why hyper and hypokalemia, as the potassium levels increase, the QRS is going to get wider, and it's going to now get rid, the P wave will go away, and what you're going to have then is all QRS complexes. So this is the reason why we don't want those levels to be high or low, because we end up with cardiac dysrhythmias, and they can go into cardiac arrest. The other thing is abdominal cramps. So I'm going to unshare the whiteboard and then go back to. So remember, with the hypokalemia in class, we talked about the ST segment depression, right? Remember that? Does that sound familiar? So you have the ST segment depression, and then you had the U wave. So the T wave is usually inverted, and it's a little bit, as you can say, more flat. It would be more flat. It wouldn't be peaked, and it wouldn't be the normal. It'd be a little bit dampened. So that would be correct. The concern we had with hyperkalemia was an individual who was on digoxin could end up in digoxin toxicity, because now they would hold on to the digoxin versus clearing it. Here, if we suspect that the patient may have digoxin, then we're going to avoid calcium supplements and give like magnesium to help. So those are our options here. So how do we treat hyper, PER, hyperkalemia? Well, we definitely need to be on a cardiac monitor. Limit potassium, so let's not give them any extra. We're already up, so we don't need the bananas and the broccoli and all of that. And then there's kind of a three-way process that can actually pull potassium back into the cell, and you can use K-exalate. So before you give that, you need to check bowel sounds, right? So K-exalate, and because that's a cathartic, so we'll make sure things are working. We can also give them insulin, so regular insulin. This is going to decrease the blood potassium. And we're going to give that insulin with D50 to prevent hypoglycemia. So the D50 and the insulin is kind of a counterbalance, but the insulin actually helps to move the potassium from outside the cell back into the cell. So to prevent now the patient becoming hypoglycemic, we now give them D50 to help counterbalance that process. All right, that would be one way. So I call it the triplicate or trilogy, whatever word you want to give it. But K-oxalate, insulin, and D50, that would be the one thing together. Or you can give them sodium bicarb. So that increases the movement of potassium from the blood back into the cell by decreasing the acidity of the blood. So when we change the pH of the blood, then we can move the potassium back into the cell, which then reverses the release of potassium out of the cell. We can look at beta-2 agonists that promotes cellular reuptake of potassium. And then if they're in renal failure, then how do we fix that problem? If we have a person in renal failure? If they're renal failure, they're probably on what? Dialysis. Okay, so those are our options there. Okay. We have calcium gluconate as an option to also help, move potassium back into the cell. But why do we not use calcium chloride? Because we have a calcium chloride and we have a calcium gluconate. So why do we not use the chloride? What's the issue with the chloride? So here it's going to be it's going to have an irritating effect when it's IV. So we're going to use the gluconate to counterbalance the potassium, its negative effects or its deleterious effects. So there's less risk of toxicity, like even from DIG. So that's the reason why we're going to give calcium gluconate instead. So it also decreases the cardiac toxicity due to the excess potassium. It decreases the risk of the patient going into VFib. So that calcium gluconate is going to work to work on the rhythm component. So that QRS complex that I drew, instead of having those tall peak T waves and that widened QRS, it's going to minimize that. So that way the QRST or the PQRST complex looks normal. So it restores the voltage, therefore keeping the balance and decreasing excitability. Questions about hyperkalemia? Let's see, I may have another picture here. Let me look real quick. All right, so I'm going to share this photo real quickly. Share. So can you guys see this? Is it too small? Let me make it bigger. Hopefully you can see that better. So here's kind of and these are just the two that we've talked about so far. There we go. So remember, the sodiums were more salt loss, where when we're here, I'm making it too big. And then here we're looking at hypernatremia. So this is now dehydration. So here's this also gives you the causes of hyponatremia and hypernatremia, and then you have hypokalemia and hyperkalemia. So these are all the things that we've already talked about. So causes of cellular movement, intracellular from the extracellular, or to the extracellular. So we're moving potassium from inside the cell to outside the cell. And so these are all of the things that we've already, witnessed. Here's your signs and symptoms. They're kind of right there in a little box for you. So hopefully that's helpful. All right. So where you want to go next? So we did the potassium, we did the sodium. So do you want to go to calcium? Because we can go there. So let's do the calcium. Let's look at hypercalcemia. So try not to get them confused, because one is cal, C-A-L, the other one is K, K-A-L. And then we'll do a case study right after that. I started talking and I was like, oh, I muted myself by accident. So sorry about that. Okay, so let's look at hyper. I think that's what I said first. So we'll look at hypercalcemia. And here what we're looking at is, we're looking at numbers. So let me go back to the other picture that I had. Let me share that one. Not that one. Okay, let's see if I can grab it from the right spot. All right, so I'm going to share this one. There we go. So I'm going to go back here. So here is the calcium, 8.5, and your book actually says 10. So someone asked me if the calcium number is going to be high. It's going to be high. It's not going to be, well, 10.5. They're not. That makes no sense. The goal is for you to understand that it's high. So here, having too much calcium is going to make the person feel really, really terrible because it's too much of it in the blood. So what would be some causes as to why an individual would have hypercalcemia? What would be some causes of that condition? What would be your thoughts? So what about like a malignancy? They can have a malignancy. They could have bone loss related to immobility. Hyperparathyroidism. Thyroidectomy. Well, if you have a thyroidectomy, wouldn't it be lower because the parathyroid is behind the thyroid glands, right? But if they had hyperthyroidism, this would also increase the hormones of that parathyroid, so you would end up with more calcium. What about your steroids? Which steroids? Would it be the glucocorticoids or the corticosteroids? Which one? Or is glucocorticoids a form, or is corticosteroid a form of glucocorticoids? Okay. All right. So glucocorticoids, they're going to also affect calcium. If calcium can't be excreted, that's going to be an issue. There's certain medications where that can happen. And then patients using lithium. So a glucocorticoid is any group of corticosteroids. So your prednisone and all of that. what happens with glucocorticoids is that they suppress calcium's ability to be reabsorbed or to be absorbed. And when it's not absorbed, then there's more calcium left in the blood. So this is for hyper, PER. The medication or medications or situations that impact a person's ability to excrete calcium is going to be those that are on thiazide diuretics. So that hydrochlorothiazide, that one, so HCTZ, that medication will reduce the ability to excrete calcium. A person in renal failure, they cannot get rid of the calcium in the kidneys. An individual with bone cancer, so that would also be a reason why that person would have some type of calcium increase in the blood, because it's not being absorbed or they can't clear it. Lithium usage. So this affects the parathyroid and it causes phosphorus to go down. So remember, phosphorus, if it's down, then what's going on with calcium? So if phosphorus is low, what is calcium doing? It's high. So that's our seesaw, calcium and phosphorus. So this person's going to feel terrible, as we said before. One other thing. How do you get an increase in calcium intake? How do we get an increase in calcium intake? Okay, milk, fortified foods, and then taking calcium supplements with vitamin D. So if you take calcium supplements with vitamin D, vitamin D's job is to help you to absorb more calcium, right? So if we take too much of, oh, I want to make sure my bones are really strong, I'm going to take a couple of these when I'm not supposed to, then yeah, we're going to have an issue. All right, so weakness, profound weakness. They're going to be too weak to do anything. So very tired, lethargic. Their reflexes, would you expect them to be active or inactive? They're going to be inactive. So they're going to be absent completely. So our reflexes will be dampened or absent. The patient will be kind of, scatterbrained. The belly, will it be flat or distended? And why? Which one? All right, we have one person that says flat, okay? Because don't forget, calcium has to do with nerve impulses as well. They do contraction. So if we don't have enough of it, then we're not going to have a whole lot of contraction going on in the gut. The belly's going to be distended because the person's going to be constipated. So if we can't move the poo along, it's going to hang around. What about the kidneys? What are we at risk for if we have too much calcium in relation to the kidneys? Kidney stones. So that's the concern we need to be worried about for if we have too much calcium, that they can actually build up kidney stones in the kidneys. All right, so how are we going to treat it? What do you think would work best? Since let's talk about the neuro very quickly. Since they're so weak and absent-minded, maybe some safety precautions, fall precautions for sure. Okay. If we're worried about stone formation with too much calcium, how can we fix that problem? Give them IV fluids or PO fluids, but they need to be hydrated. How about decreasing foods high in calcium, like your yogurts and your spinach and your sardines, your green leafy vegetables, your milk, decreasing, the medications that increase calcium. So decrease the thiazides, decrease the calcium supplements and vitamin D. That would be the first line of treatment if it's mild. So in mild cases. The other thing I didn't bring up is with the EKG changes. So from the Q, R, S, and the T, that length is going to be less than 0.12. It's going to be very short, the QT interval. And then our ST segment is going to be long. So that we're going to have a short QRST, but from the S and the T, it's going to be long. So those are our EKG changes. So from a body standpoint, we need to monitor the heart. We need to monitor GI because we talked about the constipation. We need to look at the kidneys. So we need to check our INOs, look at the urine color and the specific gravity, and then check our neural status. So other things that we could do would be to administer calcium reabsorption medication. So this is going to be for our moderately high calcium levels. So we're going to give the calcium reabsorption inhibitors. And give me an example of that medication. What's that medication name? And you guys have seen this before. Am I on here by myself? Oh, thinking. Okay. All right. So if we're going to give a calcium reabsorption inhibitor, because that's the problem that we've had, then with hypercalcemia, we're going to give them calcitonin. So let's see if I can do this right. So let's share here and then share. Oh, so here, let me clear all drawings. All right, so we're going to give them. Ooh, this looks like kindergarten handwriting. Oops. Wait, hold on. Got to erase something. There we go. This is so sad. But we would give them calcitonin. All right, so we're going to clear that. I'm going to unshare. And then what else could we give them? We can give them prostaglandins. We can give them biphosphates. And then we can give them synthesis inhibitors like aspirin or NSAID. So those are some things we could do to help drive the calcium levels back down. Severe cases. So in severe cases, how would we treat hypercalcemia? What would be your thoughts? How would we treat hypercalcemia? All right, that would be dialysis. So dialysis is for our severe case. Yeah. All right, so recap. We have hypercalcemia, so this is too much calcium. Hyperparathyroidism, the parathyroid hormones making too much calcium to be released in the blood. Then we have too much intake of calcium, so our calcium supplements or vitamin D supplements. We're on glucocorticoids. That's going to suppress calcium's ability to be absorbed. So now it's going to be too much in the blood. Hyperthyroidism, the hormones making too much, so it's going to trigger the parathyroids. Calcium excretions minimized when you take a thiazide diuretic or if you have renal failure or bone cancer. And then an individual that's taken lithium. So this can affect the parathyroid gland as well, and it can cause by driving the phosphorus level down. Once the phosphorus level is low, then our calcium levels increase, right? So some of the changes, they're going to be extremely weak, profound weakness, very lethargic, tired, absent-minded. Our reflexes are going to be absent. So if you are treating hypocalcemia, these would be the signs and symptoms you would be monitoring for to make sure that the patient doesn't have hypercalcemia. Does that make sense? Because if we don't have enough calcium, we're going to actually give it to them. So remember, if we're treating one end, we've got to make sure we don't swing them the other direction. So also belly distension due to constipation and kidney stone formation. So since we are now going to give things that's going to take the calcium out of the blood, then we have to be worried about giving them signs and symptoms related to hypocalcemia. So our interventions to treat it, we said, would be to hydrate them, so hydration IV and or PO, fall precautions, monitor neuro, GI, renal, and heart status, decrease foods that are rich in calcium and stop taking calcium supplements or thiazide diuretics. That was all the treatment for the mild case. For our moderate case, we're going to administer some medication. So we'll now give them calcitonin or bisphosphonates, prostaglandins, or aspirin and NSAIDs. In our severe case, we're going to dialyze. So that's kind of how we capture all of that in one fell swoop. Okay. You need a brain break? All right, so someone says yes, LOL. I mean, we could take a couple-minute break so that you can regroup. So if you want to do that, type yes in your chat. And then we'll pause for about 5 minutes, and then we'll come back and get with hypocalcemia, and then we'll move on. Only 2 people want a break. Everybody else is like, no. All right, one other thing, when I talked about the PO fluids, they need to get about 3 to 4, or just hydration in general. It should be 3 to 4 liters per day, by the way. Hypercalcemia does have a high mortality rate. We should also give them fluids that have sodium in it, unless it's contraindicated. How do we fix the constipation? Give them more fiber. So usually that person doesn't have enough fiber in their diet. All right. Well, since only 2 people and majority rules, so we only had 1/3 of the people that said they wanted a break, we're going to have to keep going. I'm so sorry. Or 2/3, which is still, or 2/6, which is 1/3. All right. So let's move on to hypocalcemia. This is low calcium in the blood. So this will be less than 8.6. And just kind of a recap what our calcium does. It has a huge role in our bone and teeth health. It plays a role in our muscle and nerve function, cell function, and blood clotting. Calcium is absorbed in the GI system. So problems with malabsorption like celiac disease or Crohn's is going to decrease calcium. So since we have calcium that's absorbed in the GI system, if we have malabsorption like celiac or Crohn's, then the calcium levels are going to be low. Calcium is stored in the bones, but we need vitamin D to help with the uptake. We excrete it in the kidneys, so we can't excrete too much. And calcium and phosphorus are paired together, but they have an inverse relationship. So when calcium is low, phosphorus is high, and vice versa. Okay? So with hypercalcemia, we talked about someone with hyperthyroidism, hyperparathyroidism. That would be the reason why they would have high calcium. So now here's the opposite. Now the calcium's low. So if they have low parathyroidism, so hypoparathyroidism, then we're making less parathyroid hormone, and that could be from a thyroidectomy. That could be from removal of any kind of a tumor or any neck surgery or any destruction in that area. So that can cause an individual to end up with low calcium. Oral intake of calcium is low. So folks that are bulimic or drink a lot of alcohol because you're not intaking those green leafy vegetables and all of that. Wound drainage, especially if it's from the belly, so from the GI system. Celiacs and Crohn's disease, because that's a malabsorption issue. Chronic renal failure and disease can also impact calcium levels because of the excessive excretion of calcium. It's basically wasting it. High phosphorus levels, low vitamin D intake, acute pancreatitis, and then we have a couple of medications that can actually impact our calcium levels. So magnesium supplements decrease calcium levels. Laxatives, loop diuretics. What's a loop diuretic? What diuretic do you know is a loop diuretic that's routinely given for patients to pull off fluids? And you guys know this one. You'll be like, really? Yep, Lasix.
Lasix.
Yep, furosemide. So furosemide actually pulls out calcium, but remember our HCTZ, the hydrochlorothiazides, or the thiazide diuretics, not just the hydrochloric ones, they actually make calcium stay in the blood, so it decreases its absorption. So you got to know the difference, because all diuretics don't work the same. So know that your thiazide is going to make your calcium higher. Your loop diuretics is going to make your calcium lower. And then if a person's on any type of calcium binders. Last thing is someone who's not moving. So if you're not moving, then the bones aren't getting what they need. So that's going to be a huge difference there. So instead of having absent reflexes, what type of reflexes will you have now? Because the absent reflexes was in the hypercalcemia.
Deep tendon reflexes will be present.
So they're going to be more than present. They're going to be hyperactive. The patient will still be confused, but they're going to have hyperactive reflexes, muscle spasms, especially like in the lower extremities, the calves and the feet. They can actually have seizures because of the low calcium levels. Bradycardia, BP will be low. So they'll have hypotension. Cramps. And then they can end up with pathological fractures. What's a pathological fracture? Give me an example of What's a pathological fracture? What is that? When someone says pathological fracture, what are they talking about? Osteoporosis. So usually those are fractures from medical condition. So, or from, it's a medical cause where it's not a trauma cause. Okay. Okay, so other signs and symptoms that we would have. There's Trousseau sign and Chvostek sign. What is Trousseau's sign?
It's twitchy.
Okay, and how do you know if a person has twitching?
You apply the blood pressure cuff.
Okay, so we're going to put the blood pressure cuff in the upper arm, and we're going to inflate it above the patient's systolic BP. So if my BP is 120, where are you going to pump it to?
130, 140.
130, 140. Okay. So then we're going to hold it for 3 minutes. Did I say 3 seconds or 3 minutes?
3 minutes.
3 minutes. Because what we're doing now is we're going to occlude the brachial artery. So when there's no blood flow distally in patients that have hypocalcemia, the neuromuscular area is going to become irritable. And when it becomes irritable, it's going to induce spasms to the forearm and to the hand. So you would expect the hand to flex. So Trousseau sign happens before Chvostek sign. It's kind of like latent tetany. Then Chvostek sign is hyperexcitability to the facial nerve. So Trousseau's is the one with the hand. Chvostek sign is the one to the facial nerve, which is cranial nerve number 7. So here, if you tap the patient's face on the jaw angle right in front of the tragus, so the tragus is that little piece in your ear that kind of pooches out or sticks outward, but it's going in towards the side of the ear. I'll find a picture so you can see it. The muscle that's there is now on that side is affected. So the lip or the nose will twitch away from the side that's being tapped or toward the side that's being tapped. Which one? It's going to be toward. So if I'm tapping the patient's right or the right side of their face right in front of the tragus, then the twitch, my nose or my lip will twitch over to the side that's being tapped. Okay. Can a person develop laryngospasms from hypocalcemia?
Yes.
Yes, they can. They absolutely can. One other thing, would you expect albumin to be high or low in hypocalcemia?
Would it be low?
It will be low. So MAG would be low, albumin would be low, calcium would be low. All right, so how do we treat it? How are we going to treat this condition? Should we be worried about fall risks? Yes or no? So yes, we should be worried about fall risk because we just said just a little bit ago that signs and symptoms is a pathological fracture or osteoporosis. Most patients get osteoporosis because they have a low intake of calcium. So we're going to monitor for laryngeal spasms because, you know, this can also affect the larynx, as we've already said, related to that. We're going to give them IV calcium. Now, here's the question. Are we going to give calcium chloride or calcium gluconate, Rodolphine? Which one? She's not the only one that needs to answer, but she did put IV calcium slowly. So I want to know if we're going to give chloride or gluconate. We're going to give gluconate. So we're going to give a 10% gluconate very slowly. We're going to monitor for infiltration. We're going to monitor for any abnormal cardiac arrhythmias. We're going to monitor for phlebitis because it causes tissue sloughing. So if we're going to give calcium gluconate, we really do need like a PICC line or a central line for that. We can give oral calcium with vitamin D to increase the calcium levels. And we're going to give it after the meal since it's absorbed in the GI. We can also give it at bedtime with a full glass of water. So if the patient has a high phosphorus level, then the physician may consider ordering like Tums or some type of aluminum hydroxide or sodium aluminum to kind of decrease the phosphorus in an attempt to increase the calcium, because remember, they do opposite. Foods that are rich in calcium, those are all the ones we talked about staying away from if you had hypercalcemia. So collard greens, green leafy vegetables, sardines, cheeses, milks, those are all things that are high in calcium. So since we have hypocalcemia, then we want to give them those or encourage them to eat those types of foods outside of medications. All right. Are you guys burnt out yet? We have, I think, one more. So we could either do it now or we can save it for class, which will be our last electrolyte imbalance, which would be magnesium, and then we'll cover DI and SiADH in class. So that we could do that. I'm open. I have one for class for magnesium to be covered in class. Is that it? She's the only one? Because it's majority rule. Up 2 for class. So that's 2 to 6. Up 3, up 50-50. So if we no get a 4th, we do magnesium. What's Bervecchia? Oh, so Bervecchia raised hand. Oh, okay. It raised her hand to say or do what? The hand's raised, but I'm not sure why. Is that a yes for in class, or is that a yes to continue? There
In
we go.
class.
All right. Hey, I had to check. All right, guys. So did you guys like I know that was a little funny. Did you all like the photo? I'm gonna go back to it here. Let me share it real quickly. Did you like this photo here? I'm gonna make it small because the rest of them are here as well, magnesium and calcium. I can share these with you as well. Don't have a problem. So if you think it'll help you with these conditions, then I will send this out via email once we get off Zoom. I'm trying to make it bigger and then roll it up. There we go. All right, I will send, oh, someone goes, yes, I took a picture, I love it. I will send this out, and it kind of breaks it down. What you have to understand here is that when it says EKG changes, it's not telling you what the changes are. So you're going to have to go back to what we talked about prior and how that would be impacted. You know, I'm not really sure what HESI or NCLEX is going to ask, but this would all be fair game in asking, just FYI. So I will send that out. You should already have the lab value, so I shouldn't have to send that. The other one, let me share this one and tell me if you want a copy of this one too. Let's do a new share. I don't think that's it. Hold on. Let me get to it. Let me stop sharing and then I can actually figure out what I'm trying to do. Okay, there we go. Had to click it. The other one was about the causes. So I think the other ones that I had previously, it gives you the causes as well as the signs and symptoms. The other one just gives you the causes. So I'm just going to send this one since it has both of them in one. You don't have to stress yourself over two of them, if that makes sense. All right, guys. We can call it quits for today, and then I will see you on Tuesday. I'm staying. Are we staying an extra 30 minutes later for class? I think that was the last thing. All right, so I will stay an extra. That's right, till 11:30, and then we'll do some more case studies. I'll just cover the magnesium and the hyper and the hypo for the magnesemia, and then we'll do some SI and DI, or SIADH and DI, and then we'll do case studies. So we'll see you then. Bye. You're welcome.